Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, this is Dr. Mark Sims here. I'm the host of Listen Up Podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help people to effectively treat their hearing loss so that they can connect better with their friends and family and remain independent. The reason I'm so passionate about helping people and patients is because I lost my brother Robbie twice, first to his hearing loss from radiation to his brain tumor, and then when he passed away. I only care for ears. I'm the E of ENT, who's performed over 10,000 surgeries and taken care of many more with hearing loss over the past 20 years. I'm the founder of Listen Up Hearing Center and author of a book of the same name, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to listenuphearing.com. That's listenuphearing.com. I want to shout out to Brian Urban. He connected me with today's great guest, and that's Kim Cavitt, ED. She's the owner of Audiology Resources. It's an audiology consulting firm that offers practice management in terms of operations and reimbursement consulting services and to hearing healthcare clinics. She's got an incredible background. She's a master's degree in audiology from Indiana University and an AUD from Salus University. She's given back to the community as working as a clinical audiology preceptor for the Ohio State and Northwestern. And she's also the director of professional relations at HearPO. She's authored a bunch of articles and provided numerous presentations and trainings, opportunities in audiology practice, operations management, coding, billing, third-party reimbursement, compliance, pricing, and managed care issues. I mean, she's got an extensive background. It's going to be great to explore it. Dr. Cavitt is the past president of the Academy of Doctors of Audiology and chair of the Illinois Speech Pathology and Audiology Licensure Board. So she's serving the public as well. She serves on committees through ADA and is a senior contributor to audiology online and audiology practices. I said to her, and every once in a while, she gets some sleep as well. Kim, welcome to the podcast. Thanks for coming on.
Thank you. Thanks for having me.
This is great. So tell me, how you ended up in audiology. I'm always fascinated how people end up in these fields.
I took a very difficult route. So I started in an undergrad in Indiana. I went to Indiana for undergrad as well. And I wanted to be a physician, like you are. OChem, as many people, made that not possible. I did not do well in OChem. And so then I started exploring other avenues in healthcare. I had a friend from my hometown that was in the PT school. She advised me against that it was overwhelming to her. And then I started exploring speech pathology and audiology.
Sure.
I had a lot of speech therapy when I was a kid because I had a lisp. I have an open bite. And so I had a lot of exposure to both audiologists because I had a lot of middle ear infections and speech pathologists and was really interested. My mom was a special educator. I had kind of been in that round. I thought about special ed very briefly, and my mother was like, no. But then I got into communication sciences and disorders, and I had my first audiology class in 1987 with Nick Hipskin at Indiana, and I was just hooked. I'm a very type A person, and I liked the more objective nature of audiology versus speech pathology. I liked that it was in healthcare, but it had a lot of different avenues you could explore in terms of work setting. I knew that I wanted to start, though, in a hospital system, which is what I did. But that's how I had an audiology class with Nick Hipskin, and I loved it.
That's great. A mentor, somebody who got you on fire, and you kind of went from there. That's wonderful.
Yeah.
So I assume you practiced in multiple settings. Is that right?
I have, but I spent most of my career in well, I wouldn't say most, a large portion of my career in otolaryngology. So I was an intern at Ohio State's Department of Otolaryngology Head and Neck Surgery. And then they hired me when I graduated from graduate school. I was there for 7 years as an employee of the university. then I moved to Chicago. My husband's job took me here. This was always where we wanted to land too. So that's the other thing. I worked in a training institution at Northwestern in the department, the communication sciences department. Then I did a few other things at here PO, which is a third-party administrator. Then I started my consulting business. And when I started, my mentor was the practice manager. My two primary three, Nick, and then Judy Laser was an audiologist at Ohio State. And then Jim Barlow was the practice manager. And they were really my mentors, Judy on the clinical side and Jim on the business side. And I started, my husband, when I said I was going to quit and be a consultant, he made me call Jim. And I called Jim and he goes, I think this is the best thing for you. When you quit your job, I want you to call me right back. Oh, okay. And so I called him right back and he goes, I have a job for you back in Columbus. And I go, dude, I am not moving back to Columbus. And he goes, well, you don't have to move back to Columbus. Could you commit a week, a month in Columbus? And I said, to do what? He goes, to come back and be director of audiology. And I, but I have no intention of working for the university again. He goes, oh, no, you don't have to do that. We can figure this out. And it was the first time that I went back to university, but as a consultant, but they gave me a role. I did it at Northwestern like 20 years later. But I went back to the Department of Audiology, had neck surgery at Ohio State. I was interim director of audiology. That's the way they could describe it. But I was interim for 5 years. For 5 years. And then in 2005, the university, the physicians were allowed to have a private practice in the university. The university wanted the physicians to not do that anymore. And so they made everyone decide. And by that point, we were 12 locations? 12 locations. We had a surgery center. We had 4 physicians and 15 audiologists, and they made us break up. I stayed with the private practice because that's where Jim went. And I stayed on for another 5 years. So I was in otolaryngology for 17 years, but in academic medicine for 12 of that, and then in a private practice world, I guess 17, because they all intertwined. Yeah, I worked with Brad Welling. So Brad Welling, when I was a clinical audiologist, he was my actual boss.
Right. And so what was in the mindset going from a clinical audiologist to a practice management consultant? Like what was your mindset to make that change?
So when I started OSU, audiology was in the red. So in 90, I think, when I started there, audiology was losing money. They gave me a project. With the help of my colleagues, there were three audiologists at that point, 7 physicians. I figured out the puzzle to manage care. And we went from 185 in the red to 365 in the black in 12 months. And then we just kept growing.
Right.
So I got a really strong, they put a 24-year-old girl in charge of the money and the operations of an audiology practice.
Why not? You brought it, you turned it around. But how about leaving the clinical medicine, though? I mean, making that a choice. So you left clinical to become a consultant. So that's 2 big jumps, right? You're leaving.
Right. I wore a heart rate monitor. I had tachycardia. I wore a heart rate monitor at Ohio State. Twice at Ohio State. My resting heart rate at work was 160. I had an eye twitch that the docs would make fun of, go, oh, the twitch is back. It was an unsustainable it was unsustainable to see patients, because I think I sent goodbye leaving letters to 5,000 patients. Mm-hmm. I've coordinated an implant program. When you work with someone like Dr. Welling, we did everything in audiology. So I have done clinically everything in audiology except for VEMS, because he was always having us, let's do this, let's do this, let's do this. So we were always doing this. And I got maybe a little burned out. And I realized that my skill set lied in administration. Sure. I still hold an audiology license. I can still do an audiogram in my sleep. But the day-to-day of being with a patient did not mesh with what my professional kind of goals and where my strengths lie. I mean, I consider myself a very good clinician, and I've got to really give Judy and Brad all of the praise for that, because he really, his clinical care was up here. So you had to match that. And he gave us a lot. He has a great respect for audiology, amazing respect. I'm so blessed. It took me years to meet the ugly ENT, and I had never experienced it. I worked with 25, 30 otolaryngologists. I went to Indiana. I had been trained by Dr. Miyamoto. I had only met the amazing. And so I had to practice kind of to that level, because our mantra at OSU was always patient first, and that we were going to offer the best patient care possible.
That's wonderful. And so now that you're on the consulting side, what are the big problems that you are tackling that you're seeing in audiology and clinical practice that you tackle on a regular basis? So what are those problems?
A complete, utter lack of understanding of compliance and coding and billing. No foundational knowledge from providers or even some administration in audiology or otolaryngology practice, just no fundamental knowledge of how audiology works, because it from a practice management standpoint, it works completely different than anything else in healthcare. When we tried to hire people, we would hire people from facial plastic or ophthalmology, because they have a little bit of that medically necessary, not medically necessary, private pay, not private pay background. But most people have it that are working in this space do not have a good understanding of how to run the business of audiology.
And so when you say that, you mean in terms of how the services differ, in terms of how they're delivered, paid for? What do you, I mean, I you, Widget.
All of it. So not what is the research evidence-based standard of care first, and that's consistently delivered. How do you deliver that standard of care compliantly? And then how do you make a living off of that standard of care in the way you bill things to manage care and the way you charge people privately for things that are non-covered or excluded?
So that's interesting. So I think the compliance component is the difference between the excluded and non-excluded, I think is what you're referring to. So can you explore that a little bit more for me in terms of what you mean by that?
So in a health plan, there are services that, first of all, insurance doesn't pay for 100% of everything.
Correct.
They just don't, especially when we're talking about a hearing aid and long-term hearing aid care. Sometimes a cochlear implant or an auditory osseointegrated device, a tinnitus masker, auditory rehabilitation. Those types of things aren't always covered. They are excluded from healthcare. So right. What audiologists tend to do is either
give it away, which is common,
or charge people for things that the insurance would cover. So they're topping up or upgrading or balance billing when they're not supposed to. So I see kind of both sides of the spectrum, and I and my colleagues with the leadership of my practice, we were able to make a very good living in audiology and do everything compliantly productively, like we didn't waste a lot of time. We saw people and provide quality, best practices patient care. And I can say that because we surveyed our patients after the care to make sure, were we meeting their goals? Were their outcomes what they expected? So I can say that we provided this care because we measured that. And that's possible, but you have to have solid office policies, no exceptions that everyone follows, and really a good grasp of revenue cycle from scheduling to payment. And that's something that is greatly lacking.
Well, so, I mean, what I would say is the standard of care is a big fight, right? And I think there's a lot of work on that. And I think there's a lot of awareness of that. But the compliance issue, not as much awareness, I think.
Correct.
Can you tell us a little, so what does that look like? I mean, I think I have an idea, but like, so how do you approach that in terms of, I mean, let me tell you what I'm understanding you're saying, that there are things that are covered that people perhaps maybe aren't billing from. There are things that are covered and people aren't being remunerated and maybe are billing more for when they really can't. There might be stuff where they can bill more for, they don't know it and they're not. I mean, there's kind of a lot of permutations of this issue. So I think when you're using the word compliance, that's what you mean. Is that correct?
Absolutely. That they signed a contract, but they never read it. They never read the medical policies. Let's use United Healthcare example. They have a very strict, very well-published medical policy of what they cover when it comes to hearing aids, and that they require a written recommendation from a physician.
Right.
And it has to be a physician, MD, DO. They're very clear, but I will tell you, most times when I present on this, it's like I'm telling someone this, and they have been in United Healthcare for years. But they
believe the earth is flat, and you're telling them all of a sudden the earth is round.
Correct. And good faith estimates, informed consent, telehealth consent, HIPAA. The things that I tell people about HIPAA that you can't market to your database without your patient acknowledging in writing ahead of time that they want to be marketed to.
Right.
Those are things people just, and these good faith estimates is a huge thing right now that most audiology practices have, and a lot of otolaryngology practices, and even some hospitals don't have a good knowledge of the good faith estimate and their rights and responsibilities within it.
When you say good faith estimate, can you, that is not a term I'm familiar with. Can you help me?
That is the No Surprises Act. And the No Surprises Act provisions that if you're going to see a patient and it's going to be self-pay, you're not billing it to a health plan. If you're seeing them more than 72 hours or 3 days from now, they have to have a good faith estimate of what to expect. In some hospital systems, that's going to be automated through your EHR. You're just going to whatever by the appointment type, it'll populate.
Yeah, this is how much it'll be, right?
But if you're a private clinic, you might not have that automation in place.
Sure.
And people don't understand the responsibilities of that.
And so what is the model you take to people in terms of, balance billing or that type of thing? Is it insurance specific? Do you coach them that it's insurance specific?
Yeah. So I do a lot of training events. I call them boot camps. They're 16 and a half hours long, 2 days, 4 hours on compliance, because you have to lay the groundwork of here are the rules, FDA, FTC, your state, licensure, scope of practice. I see people practicing outside their scope of practice in audiology. I take that very seriously. If you don't like your scope of practice, change it.
Within your state, not
in
just,
your state, correct?
Not just decide to practice whatever you want to practice.
Correct. I see people practicing whatever they want. HIPAA. You have to, that's where I start. And then really getting people a strong understanding of coding. What does all the codes mean and how do you use them? What are the modifiers about places of service? Documentation. People don't get that you have to meet medical necessity and that has to be documented. I talk a lot about that, and then really getting them to understand how insurance works. And then at the end, how do you price everything? Because you need to understand your managed care before you create your pricing, because you don't want to charge less than your highest payer will pay you. for an item of service. And so those are the types of foundational things I used to teach. When I taught an AUD program for 13 years. My trainings are based upon what I taught my AUD students.
Right. And so what's your typical, what do you call it, client in terms of when they arrive, how bad is it? And what are the things you have to tackle for them? I mean, I assume you get called kind of in, unfortunately, relatively dire circumstance. Is that, or?
It depends. So I am in-house audiology consultation for the Academy of Doctors of Audiology members. I've been doing it for 20 years. So members, I take around 100 member inquiries a month. Members call me and contact me all the time. That group of people tends to be a little bit more knowledgeable because they've had a lot of years with me. I do a lot of free webinars for them. I do a lot of stuff to keep them online.
It's not their first exposure to you.
It's not their first exposure. It's funny, I was just telling my husband this yesterday. I've been taking on a lot of institutional projects. I have a lot of institutional background, hospitals, otolaryngology, that types of stuff, because I've navigated those. And moving forward, I'm going to make them all start with the boot camp. Because what I find is...
That's the foundational knowledge, right?
Yes, that their problems are so big. And usually people get to me when they're losing money.
Yeah, that's a strong...
That's a strong motivator and they come to me, they have a large practice and somehow they're not able to even break even. And so I've got to figure out and to get everyone on board with foundational knowledge as we're going down this pathway. So I talk to a lot of people who are starting new practices. So in the private audiology world or otolaryngology world, if someone's starting a new practice, I end up talking and helping them create a solid foundation to begin with of what that new practice can look like. I do a lot of training. I help people with pricing as I can, because I'm very strict about compliance, because my attorney, I can't help everybody with pricing because I can't help competitors with pricing. Right. But I help people on navigate an unbundled delivery versus a bundled hearing aid delivery. How, again, do you maximize? How do you pick a managed care program to participate with or not participate with? Third-party networks, do you engage or not? And everything is looking at your individual practice, the socioeconomics of your area, your situation, and helping that manager or practice owner or director, helping them find the right solutions for their situation.
So that's great. So in some ways, I would, unless I'm speaking out of turn, think you have some semblance of, finger on the pulse of where audiology is. And so where do you think it's going to be 5 years from now?
Oh, gosh. So I'm also really involved in some of the movements in audiology. I was super involved in over-the-counter hearing aids. I'm super pro over-the-counter. I became an audiologist to help people hear and not fall down. So I want that. I've been really very involved in audiology legislation in Congress to change our status within healthcare. Audiology in 5 years could not exist. I mean, there is a possibility if we, as the collective, do not make some significant changes in the way we educate individuals, if we don't get better at advocacy and don't advocate for changes in the profession, both at the state level and at the federal level, and really get behind audiology initiatives and in time and treasure to fund it. If we don't get out of the back pocket of the 5 hearing aid manufacturers and start to think for ourselves and not let them think for us, and if we don't practice to top of license and top of scope and stop being a technician that is practicing non-evidence-based care, non-patient-centered care, where all they do is spew information and they never listen to their patient and what their needs are. And if we're not practicing to top of license, where all we're doing is being a button pusher, we have a real fear that this profession could be so diminished that it fails to really be anything.
Sure.
And I've been talking about this for a long time. So I gave my first talk on disruptive innovation in 2007. And I've been talking about unbundling since 2009. I mean, I started charging in the late 90s for all the services we provided. Some of it's private pay around implants. Implants have a lot of private pay components that you have to add into the equation. But if people if people aren't willing to invest in audiology, I see a very dire outlook. And there's been some recent research by Lonnie and Bray where they talk about the workforce issues, and they actually put this forth in data.
I talked to her before that study came out, but yeah.
Yeah, I mean, Windmill and Friedman had been talking about that even a decade ago, that we have to get smarter about how we educate people. I think the AUD was a really, I think the additional education, and I'm a little biased because I went to Indiana, and so Larry Humes had a very different idea about how you get the different education, that you have an undergraduate degree in audiology and you maintain a 2-year master's. So you push some things downward. And some of that, I'm going to defend him a little bit. Some of that is the American education system, that they want to rehash high school in college. My daughter doesn't. She goes to college abroad. And one of the reasons she picked that was, why am I redoing high school? And so it's hard to push it down because so many schools require all this gen ed.
Right.
Which made the Humes model challenging. The additional education is valuable. There's a lot to audiology, but there's a lot that we could do differently, and we could have levels potentially. I think there's a lot of changes that can be made in education to make it quicker and more affordable.
Yeah, I think the affordability issue and debt burden is a huge problem.
Is a huge problem. I think we need to really work in advocacy. I'm lucky in that I work in a very active state. We have done some amazing things in advocacy. And how I approach advocacy is, like in my state, because I've been super involved, I go to the medical society, I go to the otolaryngologist with my idea before I introduce anything and say, hey, here's what we're trying to accomplish. How can we work together to make something that works for all of us?
Rather than it being a adversarial approach.
Yeah, it hasn't been. I've had really good luck just being professional, collegial, and I actually feel I get more than most people do. I got prescription. We settled around. I got a more expansive scope. And I have a non-surgical identification rather than calling it diagnosis. And they're like, the outcome is the same. We're going to support you that the outcome is the same. I'm like, fine, okay. And they put that in writing.
So these are certain nuances in terms of the licensure.
Yeah, just nuances. And we in Illinois have probably one of, if not the most expansive scope of practice. We can do basic health screenings. We can evaluate and manage. We can do a lot of things, but we all interoperative monitoring. We just negotiated it all with the medical society ahead of time.
Have you had success with reimbursement to follow?
Yes. Well, yes and no. So let's use evaluation and management in Illinois as an example. Let's use United Healthcare. So evaluation management codes you can be a qualified healthcare provider and access evaluation management codes as long as it's in your scope of practice and licensure. So United Healthcare has a policy that says they do not cover evaluation management codes provided by Audiology. If you bill it, they will say, well, we're going to push it to patient risk. We're going to push it to contractual obligation.
Right.
We've had some success appealing with scope. Say, that's fine.
This is within our scope. You should remunerate us.
No, that's okay that you're not going to remunerate us. If it's within our scope, we should be able to bill the patient.
In other words, if you don't pay for it, that's fine, but it's within our scope, so we should get paid for it.
Correct, because the health plan can decide what they're not going to pay for or not. That's up to them.
Correct.
And the patient picked that policy.
Agreed. Or as I say, it is your insurance.
It is your insurance. And we have prior notified the patient. They knew that they were going to pay for this. They've already paid for it. Because there are some situations in audiology, if you're doing vestib well, if you're doing tinnitus evaluation well.
There's a whole constellation of things you need to check for just beside tinnitus, correct.
Implantable, anything implantable, auditory processing, that is an evaluation and management free part that goes well beyond the audiometric pre-testing.
Sure.
So it makes sense in those scenarios, but every health plan doesn't cover it. It's provided by an audiology. And when you have it in licensure, we've had some success in appealing to pushing patient responsibility. Or I have a colleague here that she was able to push a health plan to cover it.
That's great. Well, you sound like you're kind of, you got your fingers in a lot of pots there, don't you?
A lot of pots. Although I'm coming off the Illinois Academy. This is the Illinois Audiology Association. This was my fourth or fifth round, and I'm coming off the board this time. And I think that was my last. I'll still help with sunset of licensure or whatever they need me to help with, but
you're off.
I'm off the board. I'm still cheering the licensure board.
I'll believe that when I see it, Kim.
Yeah, I'm off the board. Yes.
Okay. So the next time you're on.
Yeah. No. I said this is the last one.
Okay. We'll catch up in a couple of years and we'll see. I mean, sometimes, some people are wired for this. I get the impression you're definitely wired for this.
I am, but I want to give a big but to that. I think it's important, very important to me, that the next generation of leaders gets a chance to lead.
Right.
And that I'm here as a mentor at this point.
That's wonderful.
I'm here to be your mentor, but it is your opportunity to put your face, because I'm from the AUD, I'm from the master's AUD world where we had no debt.
Right.
I don't understand their debt. So I understand it, but I don't live it.
You have to live with it, right? It's a different.
They need to be able to have their voice heard about what they want to see happen next. And I'm just here to mentor people who are interested in being mentored.
Well, that's wonderful. That's great stuff. It sounds like you're really involved in all this stuff, and I really appreciate your insights in the future of audiology. And I think there are a lot of challenges, and it'll be interesting to see. Things tend to limp along, so I don't know what's going to happen in 5 years, but I definitely agree with some of the challenges that are the immediacy. I'm not sure, right? We'll see, right?
And some of the problem is we are represented by too many associations.
There's a lot of disparate interests. Manufacturers and their interests are also disparate. Just look at the audiogram, right? Some of the people with an audiology should charge for it because it's an essential service, and other people want to give it away. And so just that initial disparity of kind of the fundamental entree point into audiology becomes a point of kind of a microcosm of the divisions.
Right. And let's even talk about the audiogram that I'm blessed that I worked with Laura Wilbur, who created the NU6. She no one understands why we're still using something that was part of a dissertation from 1960s with words like laud in it. Mm-hmm. But people will reject some of the work that's coming out of Pretoria, University of Pretoria, and some of the digits and noise, or why are we focusing on speech and quiet? And I understand in an otolaryngology setting why speech and quiet, because it has benchmarks.
Right.
It has benchmarks in otolaryngology. Get it. But from a rehabilitative standpoint or from a treatment standpoint, it's useless.
Well, I mean, I think paradigmatically, I like to use cardiology. I mean, an EKG is a very valuable tool, but it doesn't tell you really what to do. And an audiogram is a very valuable tool, but it doesn't tell you what to do. It tells you there's a problem, and then you have to do further evaluation to figure out what to do. And so, and that extends down to patients understanding that as well, right? They'll say, well, you have a hearing test. Well, I have a hearing test, but I don't have functional evaluations of how you actually perform.
But that's why we need to charge for the functional evaluation, for the communication and functional needs assessment. And it needs to, bottom line, you have to have speech noise, and you have to have inventories to learn from the patient what their needs are. A patient and caregiver interview, not talking about technology, not talking why. No one cares. No one cares. We should find the hearing aid that meets that patient's need at the lowest cost possible. I mean, that's fairly straightforward. And because the technologies of self-fitting and over-the-counter are absolutely there.
Right.
Do you know who Rodney Perkins is?
Oh, yeah, I know Dr. Perkins.
Yeah. So Dr. Perkins brilliantly, in 1995, created a hearing aid under the Resound called the Avance. And the goal of that product, it was $99. And the goal of that product was to be over the counter.
Right.
It was awesome. I cannot more strongly tell you what an amazing, it was digitally programmable. It was not digital, but it was digitally programmable. Amazing sound quality. And it got killed because it was not expensive enough.
Well,
or not.
Right. There's certainly a lot of different interests in the world in the hearing.
So many interests instead of interest, because I believe that you can do financially well and help your patient, that they're not mutually exclusive.
Sure.
Yeah.
Kim, this has been great. What's your favorite sound?
A baby or toddler's laugh. If you've seen the recent Volkswagen commercial where they're playing the Jitterbug song and she's laughing, that laugh, that like little kid, completely joyful laugh.
That's wonderful. This is Kim Kavitt. She's Dr. Kim Kavitt. She's an AUD. Her organization is Audiology Resources. It's a consulting firm. Kim, if people wanted to get a hold of you or learn more about you, how would they do that?
They can go to my website, audiologyresources.com. My training events are there. You can link to me there. You can reach out to me there. Yeah.
All right. That's great. Kim, thank you so much for coming on the podcast. I really appreciate your insights, and it's been wonderful. Thank you.
Thank you for having me.
It's been great. Thanks.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.